All right, so module 3 of the Mrso, Mrmd, Mrse course is gadolinium-based contrast media or contrast agents, which we all refer to pretty much as GBCAs. So just to start off really quickly, a little bit of background on MR contrast agents, mostly based on gadolinium. They're not all based on gadolinium, but most of them are, so that's what we're going to be focusing on. The gadolinium itself is a paramagnetic metal cation, and the way that these agents work is that they reduce the relaxation times of the protons. Classically, we think of these gadolinium agents as T1 agents, and they're administered in 35 to 50% of all MR examinations. Pretty importantly, those metal cations are combined with the chelator to reduce the toxicity. Gadolinium itself, it's a heavy metal. It's not something that you want to be free inside your body. So it's pretty important to, or the chelator is important, and the stability of the actual agent itself is really important. And we'll talk more about that as we go. One of the other things that we talk about, in addition to the stability, is the relaxivity, where the change in the relaxation rate of water protons at a given concentration, and that's broken down in longitudinal and transverse components. So we look over here at some of these different GBCAs, you can see, just like you'd expect in MR, you have a T1 relaxivity and a T2 relaxivity. Just keeping in mind that a greater relaxivity would correspond to a greater signal enhancement. So that's why we use it, right? I mean, it's right in the name, contrast agent. We use it for contrast enhancement in the images to give you better diagnostic yield. Gadolinium exhibits powerful paramagnetism due to its electronic structure. It has a lot of unpaired electrons, which give it a lot of different binding sites or coordination sites for different chemical interactions. And then you have direct magnetic interactions between water and the gadolinium, which comprise kind of what's known as the inner sphere or the really close range interactions. But then you have interactions going on at other greater ranges too. So they call those like the second shell and outer shell. And over here is just an example of one of the benefits of using these gadolinium-based contrast agents, where you can see on the left-hand side, you've got a 3D contrast-enhanced T1 weighted image. And on the right-hand side, 2D flare. This would be in a patient that has multiple sclerosis. So these types of patients, over the course of the progression of their disease, they can have a lot of these MR images. And what the contrast enhanced image gives you is you're able to pick out this subcortical lesion that's not visible on the flare image, where, MS patients, it's all about trying to identify new plaques in the brain, and you wouldn't necessarily be able to see those newly formed plaques with 2D flare like you would be able to see them if you were using a contrast agent. So just to flesh out the idea a little bit, I talked about inner shell, like mid-range, and outer shell enhancement or like influence on the water molecules surrounding the gadolinium. So you can see here, this is GAD-DTPA, which is magnavist, and you can see this kind of notch in the molecule that surrounds the gadolinium, and the notch lets this single water molecule in to interact directly with gadolinium. So that's going to be the strongest interaction, or the inner sphere relaxation. But then the presence of the gadolinium, it's basically just impacting all of these dipole interactions between water molecules. And that's important because when when all these little water molecules are in kind of a partially bound or restricted, I guess, around the gadolinium, then it slows down their tumbling rate, and it brings it closer to the Larmor frequency. So then the T1 value of water is shorter, and that's what's inducing that T1 relaxation that we talked about. So in the end, that just lends some enhanced diagnostic yield for certain types of lesions. One thing that I want to point out, though, when we're talking about contrast enhancement, when you're using GBCAs, is that the T1 shortening that we've been talking about, it dominates up to a point, but at very high concentrations, then you start to see T2 shortening. And one of the ways that you notice, or one of the ways that this is like demonstrated, is this triple layering phenomenon in the bladder, where you can see this pseudo layer. And really the takeaway point here is that the signal doesn't just increase with increasing gadolinium concentration. So you can see in this graph here in the middle, a very simple graph, the x-axis would be gadolinium concentration, the y-axis would be the signal. So as the GAD concentration goes up, the signal goes up, but only to a point, and then it comes back down. So you can look at this pseudo layer traditionally demonstrated in the bladder, where you see you have this this region of 0 GAD concentration, so you get no signal, and then the GAD concentration goes up, and then you have peak signal, and then the GAD concentration goes up even more, but the signal has started to come down. And that's just, again, just to make sure that we don't confuse the fact that you're not just going to get increasing signal with increasing GAD concentration. Eventually, you're going to have other mechanisms come into play, and your signal is going to start coming back down even as your GAD concentration increases. So as far as GBCA key properties, really, I'm not going to go through all these definitions. Osmolality, viscosity, elimination, half-life, and dose. So just this slide's here for reference. But the two that I'm going to focus on, and we've already talked a little bit about, are thermodynamic stability, which is how tightly the GAD ion is bound to its ligand, where a lower stability is associated with increased rate of nephrogenic systemic fibrosis, and we'll talk more about that. And then relaxivity, which is a measure of the degree to which a given GBCA shortens T1 or T2. So we talked about relaxivity a little bit already, which again is just referring to how the relaxation rates of a solution change as a function of the gadolinium concentration. Really, the only additional information on this slide is what are all of the dependencies of relaxivity. So it depends on the temperature, the field strength, the dissolving medium. As I mentioned, you've got all these water molecules bouncing around this GAD ion, so the tumbling rate is going to be influenced. Certainly, when you think about the water moving around this agent, the water exchange rate, the residence time is going to play a role. And then pretty intuitively, the contrast agent to water distance. We talked about these different spheres of influence, so to speak. So this is just, again, relating relaxivity of these different contrast agents, making sure we understand that they're dependent on a lot of different factors. And the relaxivity, again, the higher it is, the more contrast or the more enhancement that you're going to have in the signal. The other one that I wanted to talk more about is the GBCA stability, which is determined by the chelator's molecular structure and ionicity. So macrocyclic chelators generally bind more strongly than linear chelators. And then linear GBCAs then result in more GAD retention in the body, just because that gadolinium, it's more likely to, break off of that linear structure. It's not as well caged as it would be in a macrocyclic structure. So it's more likely to deposit in tissue in a linear GBCA and give more retention in the body. Another note is that ionic preparations are generally more stable than non-ionic preparations, and that's why this deuterium, that's pretty, you all are probably pretty familiar with from an IU health standpoint, is both ionic and macrocyclic, so it's kind of the best of all the worlds from a stability standpoint. So that's why if we look at this table, that's the most stable GBCA. So deuterium is in this highly stable category. You can see macrocyclic and ionic, whereas on the opposite end, you've got this least stable category, which would be linear and non-ionic. So again, that all has to do with the dissociation of the gadolinium. It's pretty rare, but it can occur. And when you've got that free gadolinium ion, it can be incorporated into tissue. And we'll talk about some of the health effects and potential health effects here shortly. And then just some examples of dissociation half-lives. As you'd expect, you want this dissociation half-life to be as long as possible. So the longer half-life would say that it is more stable. So just some examples here. Prohance has a 3-hour dissociation half-life, talking again about the dissociation of the gadolinium itself from the chelator molecule. Magnevis, 10 minutes, Omniscan, 30 seconds. So Omniscan, really short dissociation half-life. So as you'd expect, it's in this least stable category over here with the linear non-ionic compounds. So just to put kind of a summary table on here, it's a little bit out of date. This goes back to, they really put this together in 2010, but you can see the dosing, you can see how the stability constants compare for all these different GBCAs. and then how many cases of NSF each of these GBCAs are associated with. And like I mentioned, we'll talk about NSF here in a little bit. I just wanted to make sure to note that in 2017, the FDA issued new class warnings and safety measures due to the growing body of data that was finding issues with gadolinium retention in the body in the use of GBCAs in MR imaging. But the assessment of those health effects is ongoing, and we'll reference some of those as we go. It's just important to consider some of the retention characteristics of these agents when choosing a particular GBCA for patients, for example, who might be at higher risk for NSF or at higher risk for gadolinium retention. And you can also see here, we talked about stability. This table breaks down what their molecular structures look like, so you can compare and see how those align with the stability constants. When the FDA issued that drug safety communication in 2017, they released this table. And again, the ones that I'm calling out just from an IU health standpoint are Dotarum and Gadavist, which both have macrocyclic structures. And if we look at this little notation by them, we can follow it down here to the footnote that says gadolinium levels remaining in the body are lowest after the use of those agents. And that's due to their very impressive stability owing to their macrocyclic structure. So yeah, just to highlight those two, again, I think those are the ones that are pretty much almost exclusively used in the IU Health Network are Gadavist and Dotarum. So just to highlight those a little bit, Gadavist was FDA approved in 2011 for both adult and pediatric patients. It's a macrocyclic structure and non-ionic formulation by Bayer with a high relaxivity. And that's really Gadavist's claim to fame is I think it's, as far as GBCAs on the market right now, it's the only, it's the highest relaxivity of any of the macrocyclic structures. So it has a relaxivity of 5.2, which is higher than Dotarum, which you'll see in a sec. Still has a very good or a high stability constant due to that structure. And it's indicated in MRI for use in imaging the central nervous system, the breast, in magnetic resonance angiography, and in cardiac imaging. And one clinical note about Gadavist is that it's formulated at higher concentrations compared to other GBCAs. So it actually is, that results in a lower volume of administration. So that's just something that, well, everybody watching this presentation knows that better than me, I'm sure. And then Gadavist, just to go on about some of the adverse reactions, they're pretty uncommon as determined during clinical trials, but still around 4% of patients experience side effects up to 7 days after administration. And as you can see by this table, they're generally mild to moderate in severity and usually self-limiting. But again, because of that FDA, the precautions, the drug communication, or the drug safety communication that was issued across all GBCAs, these universal precautions apply to Gadavist as well. So nephrogenic systemic fibrosis, gadolinium retention, hypersensitivity reactions, and acute kidney injury. So again, those are less likely when you have a formulation as stable as Gadavist and Dotarum are, but that's just, it's a communication that was released across the board for all GBCAs by the FDA in 2017. All right, and the other one, Dotarum, we talked about it a little bit already. This one though, FDA approved in 2013, like Gadavist, also for adult and pediatric patients. It's also macrocyclic, but a difference is that this is an ionic formulation, not by Bayer this time, but by Guerbet. Relaxivity of 3.6, which again, not quite as high as Gadavist, but Dotarum has a very high stability constant of 25.6. And remember, we talked about dissociation half-lives, and longer the better. This one has a 338-hour dissociation half-life, so very, very stable. Indicated for use in brain or intracranial imaging, as well as in the spine and associated tissues. And now, again, we looked at that table before, a little bit outdated, but one of the current statistics is now there have been over 100 million global doses of Dotarum, and it's associated with 0 unconfounded cases of NSF, again, owing to that very stable structure. And also, because it's so stable, it's not likely to deposit in tissue, which is indicated by no visible T1 signal intensity on repeated administrations. Just to follow the same format as we did previously for Gatavist, adverse reactions are uncommon again. Still, around 4% of patients experience side effects, usually immediate or within 24 hours of administration. Again, generally mild in severity or transient in nature. I know this table, this table over here looks shorter than it was for Gatavist, and it is, but it's still, I mean, just keep in mind, it's still around 4%. I think this table just cut off at 0.2 and didn't list any of the other things, whereas the other table went down to like 0.1. So it had a lot of other reactions, but it's about 4% across the board. They're both macrocyclics. They're both very stable. And a lot of these are the same kinds of reactions you see for any kind of injectable. But then the precautions by the FDA, because it's a GBCA, just keep an eye for or toward NSF, gadolinium retention, AKI, and hypersensitivity reactions. So just to continue to highlight Gatavist and Dotarum a little bit, I wanted to call out their use in specific populations. Really, the recommendations for both Gatavist and Dotarum align very well for these different populations, so I grouped them together just to make sure that we're all on the same page. So for pregnant patients, we do know that GBCAs cross the human placenta and can result in fetal exposure as well as gadolinium retention. As you might expect, though, there's limited data in this arena, but the recommendation then for Gatavist and Dotarum is to use them only if imaging in pregnant patients is essential and cannot be delayed. So it all comes down to risk-benefit analysis, which for these agents, because they're so stable, it's generally not difficult to justify the fact that the benefit to the mother is going to outweigh the risk to the fetus. In lactating patients, again, there's limited data for other GBCAs that they do pass to the breast milk, though at quite a small fraction of the maternal dose, but that can lead to GI absorption in the breastfed infants. So again, they rely on risk-benefit analysis. And for Gatavist and Dotarum, data suggests that they're both safe for the mother and infant to continue breastfeeding after receiving the agent. So in pediatric patients, Gatavist and Dotarum have been shown or deemed to be safe and effective for term neonates to 18 years of age, according to clinical studies. There are adverse reactions, but they're not any more severe or more prevalent than those reported in adults. Also, it's worth noting that no cases of NSF, and I know I keep referencing that, we'll get there, no cases of NSF have associated with any GBCA in patients ages 6 years and younger. And then this general statement that as in any population, use should be justified. In geriatric patients, the emphasis is just on cautious use. I'm sure you all know, just from a clinical standpoint, the importance of gauging kidney function when administering contrast agents. So when you have geriatric patients, there's just more likelihood that they're going to have impaired renal function, and also that they're going to have more significant medical histories. They could have comorbidities that might complicate how those GBCAs are going to react and maybe increase the likelihood of adverse reactions. And then going along with those patients, just always keeping an eye toward renal impairment, where prior to administration, it's pretty standard to screen patients for renal dysfunction. But again, for Gatavist and Dotarum, because of their high stability, there's no dosage adjustment recommended for patients with renal impairment. But the general ACR recommendation is just to avoid any GBCA administration in cases of acute kidney injury or chronic kidney disease with the glomerular filtration rate less than 30. And yeah, you probably know that better than me. So since we're talking about adverse reactions to IV contrast, it's important to talk about risk factors. Really, the number one risk factor, it's pretty intuitive, is allergy. So there's a 5 to 8 times increased risk if there's a past allergic-like reaction or a known type reaction to a contrast agent, which again, it makes sense. If you had an allergic reaction to a GBCA in the past, it's definitely more likely that you're going to have another reaction to one in the future. There's also increased risk of allergic-like reaction to contrast agents if you have other unrelated allergies. So just if you have other allergies, you might find that they'll also have a reaction to a GBCA. It's just important to keep in mind that there's no cross-reactivity among different classes of contrast agents. So you might have someone that has had a reaction previously to an iodine-based contrast agent. That doesn't necessarily mean that they're also going to be allergic to a gadolinium-based contrast agent. It's just you know that they've had an allergic reaction before, so that's something to just be on the lookout for. Asthma is also a risk factor, which leads to modest risk increase of allergic-like contrast reaction. However, the ACR says that pre-medicating or restricting contrast agent use based solely on a history of asthma is not recommended. Renal insufficiency is a big one, and we'll come back to that when we talk about NSF. Cardiac status can play a role as far as increasing the probability of allergic-like or non-allergic contrast reaction. Anxiety, as in basically everything in the medical arena. Anxiety can be another risk factor. And then just other considerations like age. Keep in mind that middle-aged patients generally have the highest reaction rates. Female patients generally have higher reaction rates than male patients. And then similar to cardiac status are the use of beta blockers. But in both of those cases, you could have a patient with certain heart problems or having taken beta blockers, but in both those cases, pre-medicating or restricting contrast agent use, just like we saw with asthma, based solely on those things is not recommended. All right, so we talked about short-term adverse reactions. In particular, we highlighted them for Dotarum. We highlighted them for Gatavist. We know that they typically occur within 1 hour of GBCA exposure. And these, they look very similar to what we saw before for those two GBCAs that we highlighted, so we won't go through the table. It's just important to note that these fall into one of two categories. There's a physiologic category where these are actually likely caused by direct toxicity of the GBCA itself. So because of that, that's going to be dose dependent and can range from mild to severe. And probably the ones that are more prevalent, the ones that we keep an eye out for most, the second category then is a hypersensitivity reaction, where the vast majority of these are more like allergic-like or anaphylactoid reactions, where it doesn't require a previous exposure. And because these are immune-mediated, those are independent of dose. So those are those hypersensitivity reactions that we always have to look out for, which in severe cases can lead to anaphylactic shock. All right, so now we get to the final section, talking about long-term adverse reactions to GBCAs. Talked a lot about how stability plays a role here, gadolinium deposition, gadolinium-associated plaques, and NSF are what we're going to be talking about. And just keep in mind, I mean, this is gadolinium here. It looks kind of like lead or manganese or any of those other heavy metals that you really don't want in your body. And the bad thing about gadolinium is that it's like a calcium analog, so it competes with calcium and all of those calcium-dependent cellular processes that are going on in your body. So it has a lot of opportunity to disrupt those normal cellular functions, which is why it's really important to have it bound to its chelator complex, like we talked about, kind of keep it in its clamshell or keep it caged up so that it's flushed through the body without having a chance to interact and wreak all the kinds of havoc that it could as a calcium analog. All right, so first off, we'll talk about gadolinium deposition. We've known for decades that gadolinium deposits in animal tissues and in human tissues, particularly in bone, which makes sense given that gadolinium is a calcium analog. Concentration in bone can be over 20 times higher than in the brain. And we also know that deposition occurs in patients who also have, or who have normal renal function. So not just in those that have impaired renal function, it can also occur in patients with normal renal function, commonly in the globus pallidus or in the dentate nucleus, as well as the liver. And then it registers as this hyperintense signal, as we know. I mean, that's the point. That's what you want it. That's what you want it for, is to increase your contrast. The problem is that it deposits in some of those areas in some patients, and even over time, you can see that hyperintense signal. And over here, we can see this patient, I don't know what they have going on that they've needed to have this many MR images or scans, but this is their first, second, third, and 35th scan. And you can see how over time, those areas, those dentate nuclei just progressively get brighter and brighter from increased deposition of gadolinium. So it appears to be dose dependent, but there are a lot of ongoing studies, and it's a pretty hot topic in research right now to try to quantify the cytotoxicity of gadolinium, particularly in the brain. And it's also worth noting that gadolinium, because of the increased administration of GBCAs in patients, that it does go on to persist in the environment. And some groups have been looking for gadolinium and found it in rivers, lakes, groundwater, tap water, plant roots, etc. So we talked about the importance of stability and getting it to flush through patients, and then it flushes through patients into the environment. So it offers another really low dose exposure pathway, but it's out there. It's just, it's in drinking water and things like that. So it's another potential avenue for hyperintensity, though likely not at the doses, or not at doses enough to cause this kind of brightening that we see in this example here. To go along with gadolinium deposition is gadolinium, so-called GAD deposition disease, which is a proposed symptomatic disease, which is very recently described in 2016. And one of the reasons it's just been proposed is because the studies thus far have been predominantly like self-reporting. So it's the signs and symptoms that patients are reporting are medically unconfirmed. So the link between histology and the actual gadolinium, or the deposition of gadolinium, is kind of tenuous at this point. We do know that it seems that it can occur in patients with normal kidney function. But again, it's proposed because due to self-reporting, there's been a lack of control groups, some selection bias, but pretty alarmingly, some of these patients have submitted to urine testing, and GAD has been shown to be present in urine samples obtained even a month or longer after their contrast-enhanced scan. So we know that there are mechanisms that gadolinium is depositing in the body. It's still being slowly released from the body some month or months after administration. And then the patients report symptoms, usually arising within a couple of months of exposure, like skin changes, pain, joint stiffness, muscle spasms, fatigue, headaches, clouded mentation. Yeah, and really there have been some pretty high-profile cases surrounding gadolinium deposition disease. And I wanted to highlight that, yes, you will, if you look around, you will find information on GAD deposition disease, especially when you pull things off of like law firm websites, which is where I got this one. So it's always worthwhile to make sure you know where you're getting your information. There are just a lot of questions that still need to be answered about this disease. Yeah, and like I said, there's a lot of research going on regarding gadolinium deposition, trying to tie that to specific outcomes for patients. But the jury largely is still out. It's a pretty hot area of research right now. This is not a proposed disease. This one has been documented in a few rare cases. Gadolinium-associated plaques, which are rare, distinctive histopathologic feature linked to significant GAD exposure in patients with and without chronic renal disease. So it results in these variably sized erythematous annular plaques, which may calcify. The paper actually that highlights this disease is only based on 2 cases. So it's very limited amount of data right now. So 2 patients. In one patient, the plaques were asymptomatic. In another patient, they were itching, and there was an itching and burning sensation. But it was noted that this manifested in both cases in the absence of NSF. So both cases had several contrast-enhanced procedures over a relatively short period of time. They also both had pretty significant medical histories. So the interplay between the GBCAs and those comorbidities might not be particularly well understood at this point. But yes, this is just another example of a longer term effect of the administration of the GBCAs. All right, the big one. I said we would get here. This one is a very serious complication of the administration of GBCAs, nephrogenic systemic fibrosis, or NSF, which is a progressive, potentially fatal, multi-organ fibrosing disease. It manifests, like you can see in this photo here, with skin thickening. For those of you, I mean, it looks kind of like scleroderma, joint contractures, a loss of mobility, and fibrotic changes that may also occur in skeletal muscles, the heart, lungs, and the liver. It typically develops within 6 months of GBCA exposure, but nearly always within 2 years. And its pathogenesis is this transmetallation reaction, where again, we talked about how important it is to keep the gadolinium bound to its chelate complex. But in the body, you could have this transmetallation reaction occur where basically any other metallic cation in your body, say iron or zinc or calcium, switches places with the gadolinium and sets the gadolinium free, so to speak. And when you have free gadolinium, it deposits in your skin or in other tissues. And when it's there, it can incite this inflammatory response, which leads to cytokine release. And then that leads to the deposition of fibrocytes, which proliferate and cause the kind of symptoms that we described here. So as far as risk factors for NSF, really the big one is renal insufficiency. It's basically a requirement for NSF to manifest after the administration of a GBCA. In fact, no cases have been reported in patients with a GFR greater than 60. Its incidence, as we've discussed, can also be impacted by the thermodynamic stability of GBCAs, where again, both the molecular structure and ionicity contribute to their stability. And it can also be influenced by the route of excretion. We haven't talked too much about some of the other GBCAs, but the majority of them are excreted only via the kidneys, so it puts a lot of burden on the kidneys. But others, such as AOVist, undergo significant degrees of hepatobiliary excretion. And that's why if we look back at that table in AOVist, I mean, yeah, AOVist isn't used nearly as much or hasn't been administered nearly as many times as some of those other GBCAs, but because it's kind of splitting its emission from the body between the kidneys and hepatobiliary pathways, it kind of gives the kidneys a break. So there haven't been very many, if any, NSF cases associated with AOVist because the burden on the kidneys isn't so great. So the ACR classification regarding NSF, again, once the FDA released their broad warning, now the ACR has these groups to basically relate back to the table we looked at previously. So group 1 agents are associated with the greatest number of NSF cases. So these are the ones that we would associate with being the least stable or the most prone to depositing gadolinium in the body, or the most prone to having gadolinium dissociate from the chelator complex while in the body. And then group 2 agents, though, are associated with few, if any, unconfounded cases of NSF. So they are the ones that we're most familiar with in IU Health Network, Gadavist, and Dotarum. Again, we know that those are very stable, so they're associated with few, if any, cases of NSF. And here again, now that we've talked about NSF, I just wanted to put this table back so we can see if you wanted to look at the dosing, you could always look at the compare thermodynamic stability constants of the different GBCAs, and then look at the number of global administrations. Again, this is slightly dated back in 2010, but then you can see the number of cases of NSF associated with each of these. And really, because of the studies into NSF and establishing the link between GBCA administration and NSF, these days there are very, very few new cases of NSF because of the identification of at-risk patients and then applying or using these macrocyclic, very stable GBCAs in those patients, which are associated with very, very few cases of NSF. So in short, that brings us to the last slide. Just to sum up, GAD exhibits powerful paramagnetism, which results in T1 enhancement, where again, higher relaxivity corresponds to increased signal. GAD, as we've talked about, is a toxic heavy metal, so combining it with its chelating complex is very important to minimize deposition as well as any physiological interactions. Gadavist and Dotarum were our highlights. We know, and it's a good thing, that they have a macrocyclic structure. So those are associated with few, if any, cases of NSF. And then short-term reactions, remember, they break down into one of two groups. You got physiological, which is related to kind of like direct toxicity of gadolinium, as opposed to hypersensitivity related, which are immune mediated, and are, yeah, again, usually mild, self-limiting, short-term reactions, similar to other injectables. But then the potential long-term effects are where we start thinking about kidney function and the choice of GBCA in at-risk patients. And that's where we highlighted GAD deposition disease, GAD-associated plaques, and NSF. So with that, thanks everybody. Do you have any questions?